Good afternoon, everybody. I'm Dave Gustin, the former director of the School for the Future of Innovation Society and point on organizing our Enlightening lunch series, which is sort of coextensive with our doctoral colloquium in the human social dimensions of science and technology, HSD 610. And today it is my pleasure to introduce one of the newer faculty members in the School for the Future of Innovation Society, Beza Merid. Beza is has recently joined us from a postdoc at the University of Michigan. He has a PhD in media culture and communication from NYU. And he is building here in SFIS the Digital Health and Racial Justice Lab. And in his non-academic time, and actually perhaps even part of his academic time, Beza also does some stand-up. So I'm sure we're in for a interesting, provocative, intellectual, and perhaps even humorous talk. Beza.
Thank you very much, Dave. I appreciate the introduction. Hi, everybody. I'm going to go ahead and share my screen.
Hi, Dr. Beza.
I'm not sure how much stand-up there's going to be, but hopefully it's engaging. Hi, everybody. It's nice to be here today. Today, I want to talk about a new line of research that I'm launching that looks at the relationship between facial recognition technology and digital health. So as the pandemic rages on and as healthcare providers and researchers look for ways to use technology to enable safe and remote practices of care, all in the name of limiting the spread of the coronavirus, we're seeing a lot of attention being given to technical innovations as a way out of this particular crisis. But one of the lessons I think that we keep having to relearn over and over again is that technological innovation alone, without things like infrastructural support or without regard for existing inequities in society that limit the adoption of these technologies, can't solve the problems that we have with the delivery of healthcare. And so this has been the case with efforts to try and instantiate telemedicine as a way to deliver remote care. This has been the case with the coronavirus vaccine. And we're also seeing this in other sort of environments in healthcare as well. And so, for example, a similar phenomenon is happening right now with efforts to innovate how we measure blood pressure and in turn, how we try and prevent heart disease. The problem, though, is that one of the issues that we're finding is that the technologies that we're trying to sort of bring up through this process are a little bit troubling, and they're not really getting, I think, the kind of scrutiny that that they deserve. And so one of the technologies in particular that I'm focusing on is the use of facial recognition as a kind of new and transformative technology to try and measure blood pressure, right? And so one of the things I want to do is just sort of bring a kind of a more critical eye to these kinds of technologies. Okay, so why are we trying to innovate the way that we measure blood pressure? There are, I think, 3 reasons that I'm tracking at the moment. The first is that uncontrolled blood pressure is a major risk factor for heart disease and stroke. And in fact, uncontrolled blood pressure is called the silent killer because if left untreated, right, it could kill you. The second is the fact that automated blood pressure monitor cuffs, as you see on the top of the screen here, can actually lead to inaccurate readings if the arm cuffs are placed incorrectly. And then also there are issues with comfort with the arm cuffs, right? So based on sizing, if a person's arm doesn't fit in the standard cuff, then, it'll be uncomfortable and they might be less likely to use it. And then, the plan to sort of get them to measure their blood pressure at home kind of goes off the rails a little bit, right? So issues with the arm cuff is number 2. And then number 3, some patients complain that the not only the cuff, but the actual device itself is sort of cumbersome or inconvenient to carry around if they're being made to measure their blood pressure frequently, right? And so there are a host of problems with these technologies, but they are still vital for us. And so we want to figure out a way to make sure that more people have the ability to use these technologies and are sort of motivated to do so. And so as a result of that, there's a lot of talk around developing cuffless blood pressure monitoring devices. And so at the moment, there is an existing and growing literature on wearable devices like you see on the left here. So these are meant to essentially solve these kind of core problems with kind of the comfort of the arm cuff and the sort of inconvenience and all the issues that I think people are complaining about with these arm cuffs, right? They're meant to be widely available on the market. And as we're seeing now, they're really under study in quite a few places around the country and around the world. And so the wearable device is one of the, I think, prominent cuffless monitors that we're seeing, but there's also a growing literature and I think a growing bit of attention to facial recognition technology as paired with smartphone applications as another cuffless option for trying to kind of innovate how we measure blood pressure. And again, it's about sort of thinking about new ways to address these issues of inconvenience and discomfort. It's operating on the presumption that a lot of people have smartphones and they carry them with them. And so rather than hoping that people might carry one of these monitors, right, the idea is to try and use the smartphone that's already in their pocket as a way to make it easier for people to measure their blood pressure either on the go or just outside of the home. So for healthcare providers, for researchers, and for patients who are invested in this idea of revolutionizing and changing how we measure and manage blood pressure, it can be easy to understand the appeal of facial recognition technology in this regard. It's a part of this notion that it can be as easy as us taking selfies to kind of fight against hypertension, right? So this idea that we can quickly and conveniently measure our vital signs and create a record of potentially clinically useful data that can help us track our blood pressure over time and sort of use that in conjunction with the kind of advice that we get from our healthcare providers. And so it's meant to kind of represent this perhaps perfect solution to the problems that we're seeing with the arm cuff monitors. But in spite of, I think, the buzz that this particular intervention is getting, in truth, there are quite a bit of mixed feelings about the use of facial recognition technology as a potential future for measuring hypertension. There is, to be sure, quite a bit of hope. I think healthcare providers and researchers have long known about the problems with the arm cuff monitors. And so there's hope that we can find a lot of new ways to harness technology to sort of get away from the arm cuff. But at the same time, there are serious sort of sources of skepticism in terms of the accuracy of facial recognition to perform this task, the predictive ability of facial recognition. And then also, I think among some engineers and some providers, there are doubts about whether or not the science is actually there and if it's even possible, right? And so it's this really sort of interesting mix about this tension about sort of pressing forward, but also a lot of questions about whether or not we can and whether or not we should, right? And so what I argue here is that we should embrace that skepticism, and given what we know about facial recognition technology, we should use it to reject this as a possible digital health future outright. I take this position because I think facial recognition is a socially toxic technology. And in particular, I think there are two fundamental and related problems with using facial recognition to try and expand how we get people to sort of practice at-home blood pressure measurement. The first involves the technical flaws with facial recognition. So things like inaccuracies, misrecognition, and algorithmic bias. So thinking about all the ways in which the AI systems in which these technologies are based actually sort of prevent them from working properly. And the second is the racist application of facial recognition technology. So we're thinking about the ways in which they're used to exacerbate existing racial disparities, the fact of facial recognition being a carceral surveillance tool, and sort of what it would mean for that to be applied to the healthcare setting, and then also how it would sort of impact the lives of the patients who might use it. So facial recognition, I think, as we know, is notoriously poor in terms of its accuracy when it comes to recognizing people who essentially aren't white or aren't fair-skinned. And in particular, it's worse for women of color, right? And so it's also used, as I say, as this kind of carceral surveillance tool that, given these inaccuracies, right, given these sort of problems with how it actually functions, creates an unequal and particular harm for minoritized people and Black people in particular who are subject to its scope. And so if we put it another way, right, because of the flaws in how these AI systems are trained and how they're deployed, they create danger out of both invisibility when they don't recognize minoritized people, but also hypervisibility when, for example, they're used overwhelmingly to train their eye on marginalized communities and Black people in particular. And so because the effects of surveillance are not the same for all people, I think we have to keep an eye on these particular concerns. And so again, when it comes to this kind of trade-off between visibility and invisibility, in this particular instance, I'm not so concerned with invisibility, right? I think in general, I would want to raise a flag about sort of whether or not there is equitable benefit to the development of innovations and making sure that, sort of all people are able to benefit from them. But in this particular instance, visibility is not my concern, it's hypervisibility. right? So I think that we have to really question what happens if and when facial recognition technology gets used overwhelmingly on and among minoritized people and Black people, right? I think we have to question what it would mean for how that might shape how power, as it's instantiated through these technologies and as it operates through these technologies, sort of shapes the lives of the people that it surveils. And so to explore why we should reject facial recognition technology as a digital health future, I'll start by talking about the drive to innovate blood pressure measurement. I'll move on to discuss why facial recognition technology is a uniquely dangerous tool that innovates and exacerbates inequity. And then I'll conclude by talking about how we might go about imagining an explicitly anti-racist digital health future for blood pressure management and I guess broadly in the realm of cardiovascular medicine. So first up is talking about how and why we're trying to innovate blood pressure management. So just so we're all on the same page, your blood pressure is the pressure that's circulating, the pressure rather of circulating blood on the walls of your blood vessels. So essentially it's made up of a reading of two particular numbers, an upper number and a lower number. And so the upper number is your systolic pressure, and that is the pressure that's being sort of exerted in these vessels when your heart is beating. And then the lower number is your diastolic pressure, and that is the measure of pressure between heartbeats. And so if you have high blood pressure, that means you are in a particular disease risk category that is defined by a numerical threshold that starts, as you can see in the orange band there, at 130/80. And there's a bit of sort of standards information there in terms of how we define blood pressure and high blood pressure. That was changed from 140/90 recently as a means to kind of expand who is sort of caught into this dragnet, as a means to ultimately try and capture more people at a stage where they can sort of be intervened upon. And so thinking about how we sort of understand who's at risk and who gets the kind of treatment is also, I think, one of the critical pieces of information here. So why try to innovate how we measure blood pressure now? Well, first of all, cardiovascular disease is a leading cause of death and disability in the US, and high blood pressure in particular is one of the leading risk factors for developing cardiovascular disease. So we know that roughly half of all adults in the US, and so about 116 million people, have hypertension. And of those 116 million people, only about a quarter of them have their high blood pressure under control. And so the good news there is that we know that screening and treatment are both important and effective for preventing and reducing the risk of heart disease, right? But the issue is that not everybody has access to these tools equally, right? And so, for example, we also know that there are racial disparities in who has access to high blood pressure medications and who gets treatment for it, but also disparities in who actually gets high blood pressure. Right. And so there's a really sort of urge to make sure that we're doing this as sort of effectively as possible and as equitably as possible. There's also, I think, an importance to thinking about how we might improve the tools that are disposal. And so again, there's this knowledge about this dissatisfaction about the tools that are sort of at our disposal now, right? And so we know that the blood pressure arm cuff is a problem for a lot of people. And so when we've coupled that with the idea that there is this ongoing debate about the ethics of facial recognition technology in particular, I think now becomes a really opportune time to start thinking critically about how we can shape this conversation, and in particular, how we can try and influence institutional thinking and regulation as well. Okay, so what does it mean to use facial recognition technology to measure blood pressure? I'm going to just briefly discuss a study that appeared in one of the American Heart Association journals that talks about this kind of technology. So this study was done by researchers in Canada and China on subjects who were in China, and essentially used a technology known as transdermal optical imaging, or TOI. And the idea was to essentially, using a smartphone, create a 2-minute video of a patient's face, right? So there's light shining on the patient's face, the iPhone is stationed in front of them, and it's recording video. And the idea was to use this TOI software to measure the circulation of blood in the subject's face. At the same time, as you can see in the diagram on top, their blood pressure was being measured by a continuous blood pressure monitor to get a baseline reading of what their blood pressure was while the video is being recorded. right? And so the goal of this study was essentially to train a computational blood pressure model against the kind of baseline reading of the arm cuff blood pressure to get a sense of whether or not the TOI software could accurately predict blood pressure based on what it looks like when blood is sort of flowing through the face, right? And so they used, I think, something like 2,000 subjects. And from what they report in their findings, they say that their ability to predict the systolic and diastolic readings of these subjects was above 90% in both categories. And so they claim, a lot of great success here. They say that this could be a technology for the future. And in fact, there was a lot of sort of fanfare about this as a kind of revolutionary technology, and still being discussed both in the popular press and among cardiologists and vascular neurologists today. And so in thinking about how this study is kind of guiding some of the conversation, I became really struck in particular about what this fanfare is touting, despite what the authors themselves acknowledge as the kind of key limitations of their study. And so they talk about how their subject base didn't include anyone who actually had high blood pressure, which seems like a bit of a red flag. And then more, I think, to the point of the work that I'm doing here, they talk about how their subject base was both racially homogenous, consisting of people entirely of East Asian descent, and then also consisting of people who didn't have either very dark or very fair skin. So sort of right down the middle. And so they didn't really have, I think, an adequately sort of diverse training set in terms of how they're training their AI. And so they flag these issues and they say that, this is something that we should look at for future study. But again, this is, I think, one of the troubling things here. However, to the extent that providers and researchers do sort of take up this mantle and sort of this call for future study, I think when we're kind of thinking about what this might mean for the field, it seems like for people who do want to sort of continue with this work, there might be an emphasis on algorithmic fairness and bias, and there might be sort of an emphasis on those tools in particular to try and make sure that as we are developing facial recognition as the measurement for blood pressure, we're doing it as fairly as possible, right? And so, it's tempting, I think, to sort of opt to sort of take that conclusion, right? To sort of think about greater visibility of subject groups that are sort of left out of these benchmark data sets as the kind of path forward to make sure that this technology is as equitable as possible, right? It's tempting to think about addressing how algorithmic bias functions in healthcare systems, right? How it compounds existing inequities as the path forward that we need to follow. But what I argue here, again, is that in this case, visibility is very much a trap. Right? I think that, in fact, we shouldn't make these systems better at recognizing patients' faces. And in particular, when we're talking about racial inequities for access to healthcare and in terms of the incidence of disease, I don't think we should make these systems better at recognizing the faces of minoritized and Black patients in particular. Right? I think we should opt to instead try to abandon these technologies and ban them outright. Reason is because, as I say, facial recognition technology is a uniquely dangerous tool. And so when we talk about using facial recognition technology in digital health in general, and also as a tool to ensure the equitable distribution of the benefits of innovation to minoritized people in particular, I think we really do have to reckon with the unequal harm that's visited upon marginalized populations by these kinds of technologies. We have to situate our understanding of how facial recognition technology as a potential cardiovascular innovation would work within the context of the often discriminatory uses to which it is, I think, already put to work. And I think we have to understand this in particular as a violent form of care. Facial recognition is so dangerous precisely because it surveils, records, categorizes, and distributes data about an intimate part of our lives, our faces, right? And so we know that our faces are hard to change or hard to hide, and that in particular, they're central to our personal identity and our social lives, right? And so when we're thinking about reasons to kind of get away from this furtherance of facial recognition within an existing surveillance infrastructure, I think the kind of personal component of the face is one of the issues. But also, we already have existing databases that connect faces to names, right? We already have an existing video surveillance network. And also, I think what is most, pertinent to the argument that I'm making here, one of the issues that we really need to try and get away from using facial recognition technology in this way is that it accustoms users to seemingly benign surveillance practices and to privacy loss, all in the name of convenience, rather. right? So I think that is something that we really need to be kind of watchful about. It can be useful when we're thinking about these critiques to kind of take a kind of broad approach and to think about maybe a universalist argument about sort of privacy loss. But again, when we're talking about this kind of technology and the way that it tends to operate, I think that we really need to talk about the particular threat that's represented by the kind of unequal burden that's shared by minoritized people, right? We have to understand that facial recognition technology as a surveillance infrastructure is racist. And we have to reckon with how facial recognition gets used in particular to surveil minoritized people, and how racist biases and beliefs that are used to inform who gets surveilled, right, basically sort of feed into these systems and then essentially amplify, supercharge, legitimize, and institutionalize these biases. We have to grapple with what it means for a technology that so often misidentifies and mischaracterizes and misrecognizes particular populations, while also subjecting them to carcerality, right? We have to grapple with what it means for that kind of technology to be taken up by healthcare providers. And we have to anticipate how algorithmic discrimination and carceral surveillance will transform healthcare for these patient communities. And so as we're going about this work, right, I think despite what we may want to hope for in terms of good actors and people with the best of intentions, I think another thing we have to do is really anticipate how these kinds of technologies will be abused, right? We already live within a surveillance infrastructure that tolerates, if not explicitly promotes, mission creep with a lot of these surveillance practices. And so I think one of the questions we have to ask is what it would mean for facial recognition technology to be taken up as a digital health tool. And in particular, what it would mean for these vulnerable populations. Right, we might ask, for example, if we might see something akin to what we saw with Project Greenlight in Detroit, Michigan, which essentially was a surveillance project operated by the police department, where they distributed high definition cameras on street corners and all around Detroit as a means to sort of participate in community policing in order to fight crime. And so what they did was they recorded these videos, they streamed them back to the police department, and the videos were used to be tested against criminal databases, driver's license databases, and state ID databases. And as you can see from the map, and as you might guess on your own, right, the distribution of these surveillance stations was heavily correlated with majority Black communities. And so given what we know about sort of frequent contact with the police in terms of the harm that that causes, I think we can use that to think about the harm that might cause, that these kinds of surveillance infrastructures might cause for patients if they are exposed to these kinds of networks. And so because of these technical flaws, because of what tends to be a racist application, and because of the ways in which it amplifies and legitimizes racial biases, I think it makes a lot of sense that the sort of argument that critics make in terms of facial recognition being toxic to our lives as social beings and sort of its widespread use not outweighing the risks really, I think, makes a lot of sense and is an argument that we have to take to heart here. But, you know, despite these concerns about sort of our growing surveillance infrastructure, as it turns out, data collection and tracking via AI surveillance is only increasing during the pandemic. And so again, you know, it's easy to understand how in moments of crisis, right, when we're scared and we're looking for sort of institutions to find ways to kind of reduce harm, it's easy to understand how we might sort of ignore some of our concerns about these kinds of privacy intrusions. But in spite of these fears, and especially during these moments of crisis, I think we really do need to be mindful about how we normalize surveillance in any regard, right? And so whether it's in terms of fighting crime or tracking the spread of coronavirus, or in this case, reducing the risk of heart disease, we need to be sort of very careful about the doors that we open along that way. And so one of the ways that I try and conceptualize how racialized hypervisibility could shape the delivery of healthcare, right, is by thinking about what it would mean for populations that are already subject to this kind of hypervisibility as a condition of their accessing healthcare. And so I think about people who get their healthcare through Medicaid or welfare or other public benefit programs. And I think about the ways in which their lives are made to be sort of open to federal and local agencies for scrutiny, for fraud, and all kinds of things, right? And it's a kind of scrutiny that we don't tend to see for people who have the money to pay for, I think, better quality insurance, right? right? So they are conditioned to search and all kinds of questioning, presumptions of cheating, right? And for sure, a lot of coercive rules. And so I think about what it would mean for these particular populations who really have no other choice, right? To then be scrutinized further with this kind of technology. And so for example, if facial recognition technology as a blood pressure tool or as a sort of vital sign tool was used largely or primarily among the indigent or among minoritized people as a condition of eligibility for these programs, for example, what would it mean for their lives and sort of their sense of security to sort of constantly be subject not only to this kind of intrusive questioning, but also to this kind of carceral technology as well, right? And so even if the data are safe, even if there is no ill intent, even if it's otherwise benign, I think the fact of sort of taking up these kinds of carceral technologies and these surveillance tools is a problem that we have to sort of deal with. And so I think that's really the kind of crux of it, right? I just don't think that the convenience and sort of the charm of innovation in terms of how we sort of advance health screening outweighs the risk of the racializing effects of facial recognition technology. And so to be fair to its proponents, right, there are a lot of potential benefits. There is legitimately a lot of reason for hope in terms of how it could advance the practice of medicine and in particular diagnostic care, right? So when we're thinking about what individual clinicians are able to do sort of as humans, right, versus what sort of large scale data sets are able to do with this kind of machine learning, right? There's this idea that we could find through these large sets of data subtle correlations between facial morphology and genetic disorders, right? There's this idea that facial recognition could be used to help visually impaired patients as an assistive device, right? There's this idea that it can be used in emergent settings to try and gauge if someone has a difficult airway or if someone is struggling in a way that perhaps cannot be perceived necessarily or as well by the human eye. There was maybe some more dubious information about sort of whether or not it could predict depression, but still there is this kind of hope that of all the things that we are able to do as people, right, machine learning could do it so much better. And so you get a sense of sort of why people kind of invest in the idea of these AI-enabled practices of healthcare as being sort of huge advances and huge opportunities, right? And then, you know, especially during the pandemic, right, it's easy to see the value add of what facial recognition could potentially do. We're at a moment when we are trying to increase social distance. We're trying to make sure that our sort of modalities for providing care are safe and hygienic. And so if you think about walking into a clinical setting and having a facial recognition technology sort of do a contactless check-in and sort of confirming your identity and immediately accessing your electronic health records, right? You can see, you know, the appeal there, especially for clinicians who are sort of in the slog of this daily work. Anything to kind of make sure it's as efficient as possible seems really appealing, right? And then likewise, when it comes to, again, thinking about how we might advance how we measure hypertension, we could try and address all these sort of common issues that make it difficult for people to kind of take up the practice of at-home blood pressure measurement. And so, at least in a vacuum, it's very easy to understand these kinds of appeals. And in fact, there are some researchers who even go so far as to say that AI-enabled healthcare is very much inevitability, right? It's sort of the way of the future, and we're already there, and we're sort of locked into this path. And so, to the extent that that is true, I'm not sure that it is, but to the extent that it is true, I think we still do have a responsibility to do as much as possible to constrain the use of facial recognition technology and sort of make sure that we're at least trying to ban it in modalities that are not absolutely vital, but otherwise making sure that we're sort of constraining it and regulating it as closely as possible. And this is because despite all the possible good that could come from these kinds of technologies, right, it still does distribute harm inequitably and often along the lines of race. And to do otherwise would require a substantial amount of work that we're just not sort of ready to realize at the moment. And so because of all the sort of mountains that I think are between us and this kind of promised land of facial recognition as sort of the digital health future, right, I really do think that we have to kind of reject this path and just find other ways to innovate if that is the goal that we're seeking, right? I think one thing that we should be encouraged by is that there are a lot of efforts to reflect on, to seek public comment about, and to ultimately try and regulate or ban facial recognition technology happening within the federal government and with, to some extent, some local governments as well. These efforts are being led by researchers and patients and communities in which surveillance is very much a norm. And so I think there's a lot of reason to sort of be encouraged about the kind of fight against the spread of these technologies. But one thing that I am a little bit concerned about is that there doesn't seem to be that same kind of fight within the world of healthcare. And I think it might be because the kind of charm of innovation is sort of cutting down on this work and really sort of advancing our ability to really revolutionize how we treat patients is, I think, hard to resist, right? And so the kind of toxicity of facial recognition and kind of the public discourse doesn't seem to have reached the world of healthcare providers and innovators in the same way, right? There are people who are skeptical, but it isn't that sort of same sort of outright rejection of facial recognition technology. And so one of the things I'm curious about is sort of why that is. And I'm also curious to kind of chart what it would take to kind of get healthcare providers and innovators to sort of catch up to the broader discourse around sort of this rejection. And so I think because of all these things, right, facial recognition is anathema to racial justice broadly, and in particular to our efforts to equitably distribute these kinds of benefits of innovation and to eliminate racial disparities in healthcare in particular, right? And so because of this, right, because this is, I think, incompatible with sort of our aims towards racial justice, I think we do have to resist it. And when it comes to resisting it, I think we need to be forceful in our rejection, right? I think we need to be unequivocal and clear and sort of resolute, right? And so when stakeholders ask if facial recognition technology should be a part of how we revolutionize blood pressure management, when they ask if these technologies should be a part of our digital health futures, or when they ask if they should be a part of how we advance care in this pandemic or the next, I think, again, resistance is required, but it has to be a resistance such that, you know, there is no other option, that we always sort of make sure that every sort of debate about these technologies always sort of returns to these inequitable harms and the sort of profound harms that they cause to these particular communities. Okay, so what might it look like if we instead had anti-racist digital health technologies? And how might they contribute to an explicitly anti-racist digital health future in general, but also within the realm of cardiovascular care? For one, I'm not entirely convinced that we need cutting edge technologies to kind of advance these goals, right? When it comes to making sure that there is an equitable benefit to our technologies and to our efforts to expand care to people, I don't know that facial recognition technology in particular, or these kind of other cutting edge technologies that rely on AI are really the key to the problem. Just as opponents of facial recognition cite the prevalence of existing databases connecting faces and names as a reason why we don't need to sort of draw on facial recognition to kind of further establish our surveillance infrastructure. I think we can also make the point that we have existing blood pressure measuring technologies that can be used and that can be adapted and improved to kind of explore these aims and to sort of further these aims rather than immediately kind of relying to a kind of relaxation of our sort of concerns about data privacy. And so for one thing, you know, we're certainly not at a lack of imagination, right? I think as Bard et al. Argue in a recent article talking about a sort of journey to develop cuffless monitors, right? We are at a point now in healthcare where we have something akin to these kinds of Star Trek style medical tricorders where you can measure vital signs by touch alone. And so clearly, you know, we're not at a want for imagination. So I think the key thing that we need to think about here is what it would mean to be more imaginative about racial justice rather than just the kind of technical tools that we use as a part of healthcare. Right, so rather than focusing on expanding our surveillance infrastructure, we could think about adapting the technologies that we have in order to make sure that they work better within particular contexts, right? So if the cuff is such a big problem, we can think about investing in patient training to make sure that everybody who uses one of these monitors knows exactly how to use the cuff and knows exactly where to place it, right? We could think about working with patient communities to design more comfortable cuffs, right? And so thinking about how we can sort of talk about and include the expertise of different stakeholders, I think is a better way to go here. We can make standard the inclusion of variable sizing in cuffs to make sure that for patients whose arms don't fit in standard cuffs, they still have an option, right? So we could just sort of include that in the kinds of boxes that come from drugstores or wherever patients tend to get their blood pressure monitors. And I think one of the key things we can do is ensure the universal provision of these monitors, regardless of insurance status. And so one of the findings of a study from the American Heart Association's policy shop a couple of years ago was that there are quite a few people who have a number of cardiovascular disease risk factors who are uninsured or underinsured. And so thinking about sort of reimbursement costs for these devices, thinking about out-of-pocket costs, right? We can make sure that if we're going to do some sort of advocacy work here, we're not focusing just on the technology, but on sort of intervention around it, right? So I think this is one of the opportunities that we can pursue. Another thing we can do is think about sort of what it would mean to design digital health technologies in the public interest, right? So thinking about how we can work with different stakeholders and different bodies of expertise, and in particular, work to define these kinds of interventions along common values, right? And so thinking about data privacy and infrastructural barriers, thinking about sort of what it means to include people with different expertise, but also in particular, thinking about the kind of power that flows through these kinds of interventions and what it means to either deploy facial recognition or to reject it, right? I think power has to be one of the kind of points of our intervention as well. Rather than focusing on cutting edge technology, again, we can think about what on an earlier slide I talked about as this kind of typography of power within these kinds of deployments. So we can think about what it means to have these technologies sort of dropped into particular communities. Instead of thinking about advancing facial recognition technology and maybe adding in a kind of fairness component or adding in a kind of auditing component, right? We can kind of stop and think about what it means to have these technologies within particular communities, but also what it means to innovate in this regard and how our efforts to innovate may actually shift or reinscribe or consolidate power. And in particular, what that means, again, for these vulnerable communities. So right now I have my eye on the American College of Cardiology and the American Heart Association, and in particular, their research centers that focus on healthcare and innovation as sort of potential sites where institutional change could take place. That's not to say that these are the only sites. Certainly not to say that community organizing and sort of researchers don't have a role outside of these institutions, but I think that these institutions in particular are an interesting place to study how it is we conceptualize the kind of social function of innovation and what it is that, for example, providers and researchers who are working towards these ends think that innovation will do, right? And so I'm curious about sort of how I might get in to talk to these people. I'm sort of trying to pull some strings to sort of make my way in, but I think this is one of the sites of intervention that I'm looking at next in this line of work. And to the extent that these technological innovations are inevitable, to the extent that they do sort of press forward, I think it'll be important for us to have common frameworks for responsible innovation. And so making sure that there is some form of accountability, right? Some sort of widespread understanding of the kind of needs of these different communities with regard to the deployment of these technologies. And so consulting this literature, I think, will be important no matter what. But either way, I think whichever direction this field tends to go in, it seems like there's going to be some really fascinating opportunities for thinking through what it means to kind of pursue racial justice within the kind of world of cardiovascular innovation. And so I think to that end, there are some good opportunities for potential student collaborations. So if there are any doctoral students who are interested in maybe talking about the relationship between facial recognition and digital health, or what it might mean to think about a kind of national strategy around digital health. And then in particular, responsible innovation and also kind of ideation around anti-racist digital health features, please do get in touch. I'd love to talk about that and potentially explore opportunities to collaborate. So with that, I'll go ahead and wrap up, and I'd be happy to take any questions.
Great, thank you so much, Beza. Incredible sort of scope and detail together in one talk. I know I have at least a couple of questions, but I want to see who online might want to start. And if nobody's ready to jump in, then
I could ask a quick question.
Please go ahead, Ritz.
Yeah, hi Beza. Thanks for that interesting presentation. My question is, and let me say that first of all, this is a topic that's close to my heart for literal reasons, having gone through a lot of these different types of measurement devices and use them. But is your objection primarily to facial recognition being used in this way, or do you think that other types of innovation that would make it more convenient to measure blood pressure or other things, like, for example, suppose the 2-minute video wasn't of your face? What if it was a 2-minute video of the blood pumping through your hand and AI was used? Clearly that would still have the same sort of racial information, but it's not necessarily facial recognition. So I guess that my question is more about that. And then my second question is, couldn't these technologies, you focused on the harm that could be done to certain minority communities, but given that certain communities are more likely to have cardiovascular issues, particularly in the US, like, for example, South Asians, wouldn't adding some of these conveniences actually help certain minority communities unequally, I guess? Those are my two questions.
Great, thank you. Yeah. So as to the first question, I think my objection is to facial recognition just in general, but also to this kind of focus on thinking about innovation as the way out. And so before I came to ASU, I was working in a research center where we were trying to design a wearable device, and there was a lot of sort of faith in the wearable device as being kind of a silver bullet. But I think one of the things we see in the literature that's critical of that is that because of all the kind of infrastructural barriers and all the kind of social context around these technologies, despite how well we try and design these technologies, because people either have trouble paying for these devices, or they don't have data plans, or, for example, if we're trying to get people to sort of get outside and exercise through like a mobile health intervention, if they can't get outside because their neighborhood is unsafe or the sidewalks are unpaved, right? There are all these sort of barriers to using innovation as kind of the silver bullet. And so my opposition is not really to innovation on the whole, but to sort of the innovation that doesn't take into account all these barriers. And so I think one of the keys there is sort of designing these kinds of innovations in context and with particular communities in mind, but also understanding that if we are relying on sort of people having mobile phones and consistent data plans that they can sort of pay month to month, then we are already sort of running into problems there. And so I think that's one of the issues with the first question. As to the second question about whether or not minoritized communities wouldn't still benefit from these technologies, I think they could. But again, it's the sort of same issue about whether or not the kind of broad issues around using innovative technologies are even sort of possible for them. And so there was just an article that I saw that I haven't had time to read yet, but I think it was in Wired, or I think in the popular press somewhere, about this idea that through a meta-analysis, some people found that all these innovations still are only helping people who are wealthy and who have the money to afford them and the money to sort of get regular exercise and all these things, right? And so it's not that innovation is bad. It's not that all wearables are bad or whatever it happens to be, but just that I think when we're designing these tools, we really have to, at a pretty fine-grained level, make sure that the actual people who we want to benefit from them are still able to actually use them day to day.
Okay, thanks very much.
So let me ask my question as a kind of a follow-up to that, that if you want to try to get leverage onto how these kinds of innovations might perhaps even preferentially help people who are underserved by medical innovation, what do you need to do to fix how really crappy that study that you looked at was?
Yeah, so if we were committed to making sure that facial recognition technology worked, which I am not, then I would make sure that the sort of benchmark data sets were racially diverse, that they had people with different skin tones. And so if we think back to work like gender shades and all the sort of critical work around why facial recognition has these inaccuracies and these biases, right? Making sure that you have sort of demographic variance in these kind of training sets, I think would be the important thing. So that's number one. Number two, we could try and invest in efforts to sort of audit these technologies. And so when we think about the data that goes in to train them and to eventually update them, right, making sure that they're as representative as possible is important. Also making sure that the technology functions well with, I think, smartphone cameras of a variety of qualities, because I think one of the things that we see is that the cameras on a lot of smartphones aren't necessarily all that good at picking up people with darker skin tones. And so I think it would require making sure that the study is more intentionally designed. It would require making sure that the technologies available are sort of more inclusive in terms of who they serve. And then also making sure that, if possible, right, these particular technologies around facial recognition aren't a part of a kind of broader surveillance dragnet. And so thinking about what it would mean for abuses of these kinds of technologies, I think means that there would have to be some pretty ironclad protections about sort of what patients could expect in terms of their data not being co-opted by whomever, right? But also I think even with all that, even with all these good intentions, I do still worry that just sort of the process of using facial recognition technology. So if we just talk about that, and we can talk about wearables later. If we talk about that alone, I think just the process of using what is, I think, a carceral technology as a part of your health still feels a little harmful to me. And so my preference is to just sort of take that off the table altogether. If we're thinking about how do we make sure that these populations are better served by wearables or things that are not sort of that same, I think, category, there are ways to work with communities. There are ways to make sure that when you're designing these studies, when you're designing these technologies, you're not designing them for a community, but rather designing them with a community. And so making sure that you talk to them very specifically early on and frequently throughout the process to make sure that this is like a needs-based technology design rather than here's what we've designed, use it, and hopefully you're okay, And so there's a way in which sort of community engaged research, I think, can guide that process to make sure that it is as close to the community needs as possible. But it's just that I think with some technologies, they just seem, so toxic and so challenging that I think they should just be taken off the table.
Are there ways, hang on a second, Ben, are there ways of getting that kind of sense of what is needed on the research side in front of not just the researchers who are doing it, but journal editors and peer reviewers? Because I'm still sort of astonished. That study that you showed at the beginning sort of grabbed me by the throat. I mean, there's all sorts of literature about why the scientific literature is screwed up, but that was a good example of a screwed up piece of literature.
Yeah, so I think there are a couple of things there. One is that to the extent that these research bodies like the Centers for Innovation at the American College of Cardiology and the American Heart Association have any kind of like auditing committee or any kind of sort of responsible innovation committee, right? I think that would be a place to raise these kinds of concerns. And I think it would be useful to make sure that if they don't have those committees in place, then they know that, for example, social scientists are very alarmed and are not as kind of thrilled about these technologies as maybe some of the providers are. And so making sure that they have these kinds of critiques sort of up close and personal in their spaces is important. But also one thing I'll note is that a lot of these researchers are journal editors, right? They are the people who are approving this literature. And I think one of the issues is that it's just a kind of different orientation to sort of this technology, because the idea is I'm in the clinic, I'm seeing these patients, they have this problem, we need some kind of innovation, patient education maybe isn't working, maybe technology will. And so a lot of times I think there is a very, I don't want to say singular, but a very sort of strong focus on we gotta go down this particular path, right? And so I think whether or not you raise these concerns, there might still be an orientation towards, well, but like, it would be good to do this to improve management or whatever, right? And so I think whether or not people are raising those concerns, they might still be more inclined to using these technologies. And so I think that's why, we have to sort of go back to just like a forceful rejection of the ones that maybe are probably going to be difficult or impossible to regulate. And then otherwise very close scrutiny on everything else.
Thanks. Ben.
Beza, it's really great to meet you. I really appreciate the talk. So I have kind of a maybe open-ended question for you here. I totally hear that you, and correct me if I'm wrong here, you seem to be kind of segmenting some of the concerns into, on one hand, focusing on the cultural valence, cultural valence of the subject to facial recognition, that it calls a carceral affect into the room in a way that is punitive and so the optics of the situation are one that we should be concerned about on one hand. On the other hand, I understood you to be playing on the concerns of how facial recognition supply chains become entangled with the carceral state. And so I have two questions about that. One is, I understand that this talk is probably not all encompassing of your work or your perspective on what we should be concerned about here, but I'm curious about, you centered the carceral state. I wonder how you think about various racializing markets. So for instance, the credit market, the insurance market,
The what? Could you say that again?
the insurance, health insurance market, the housing market, particularly for assistive housing, how facial recognition data could make its way into these marketplaces, which already have this racially stratifying history and present, right? And with regards both to the carceral state and maybe these private or public-private marketplaces, why would there be a substantive difference between facial recognition data and any other form of biometric data, including those collected by wearables, for instance? I have other questions, but maybe I would love to chat one-on-one some other time. I'll leave you that for this forum.
Yeah, sure. So I think you're right. I'm trying to segment those two and raise critiques about both, but in the moment, I'm concerned about the kind of carcerality of this kind of technology. And so I think that is the argument that I would make to this kind of audience. I think for one reason or another, I think providers and healthcare researchers in sort of clinical spaces may be less inclined to be persuaded by that kind of argument. And so I think it's a bit of a sort of selective game in terms of how you kind of position the critique here. In terms of these kinds of racializing markets, I think you're right to flag that concern, because what we know is that, for example, insurance providers already have access to troves of data about sort of our own individual health status based on, you know, the things that we search online, the things that we buy. And so I think there is concern about what data are flowing about that we don't know about. And so, you know, whether it's wearable devices, which by the way, I'm not especially fond of as well, right? So like in my previous job, we were designing this wearable device, and there came a point when we were sort of getting ready to test it out before sort of distributing it to community members. And so we were all asked to wear these wearable devices for like a week or a month or whatever it was. And I refused because in general, I don't want to, but also the idea of just like handing over like wearable data and sort of health data to my employer just seemed a little weird. And so in general, I'm very leery of the entire operation. And so I think there is this kind of core tension at play here about the desire to want to advance care and advance the technologies by which we deliver care so that people who are underserved can benefit as much as possible, right? But then on the other hand, this sort of recognition that there's this whole undercurrent of how these data are sold, and, you know, the sort of opacity of, you know, who has access to them and sort of what happens to them when they're bought and sold and traded. And so, you know, it's this sort of weird position where, particularly, you know, for example, in a school of innovation and society, right? This idea where we, I think maybe are charged to kind of really consider the values of these kinds of innovations, but also are perhaps skeptical about sort of a lot of the ways in which they're deployed. And so, you know, I think it is important to be critical and be mindful of the fact that these data for sure could be traveling through these racialized markets, and I would imagine probably are. I don't know, but that's another thing to kind of tap into, right? When it comes to other kind of biometric forms of data, yeah, I think anytime that, you know, we see opportunities under the guise of sort of like equitable distribution or equity and inclusion or whatever it is to make sure that underserved communities have these technologies, there is a part of me that always wonders, well, to what end, and, you know, for whom, and like who's looking at these data, right? And so I am always sort of immediately suspicious of those kinds of data transfer agreements, right? And so I worry about that, but at the same time, you know, if we are in this stream where like we're already down the path, right? We're already sort of in this inevitability of AI-enabled healthcare. I guess responsible innovation is the way to go, right? But even still, I feel like I'm going kicking and screaming a little bit, you know.
Thanks. I'll give space for other people to get in here, but I appreciate the answer.
Okay, I see you in the chat. Do you want to raise something aloud?
Sure, it was more like a comment, but before I get into that, thank you for the wonderful lecture, and it was very insightful. So, especially that study which used facial recognition technologies to measure blood pressure. Like, I was wondering if even it's a scientific way to measure blood pressure in the first place, because this probably examining how the blood is flowing in your skin or under the skin in the face can be affected by so many other different biological reasons. So just because we have a technology in place doesn't mean that it is the right way or the scientifically accurate way to conduct an experiment. So this was more a comment on the philosophy of conducting science. So yeah, I'm wondering if you have any comments on that.
Yeah, no, I think it's a great point. And in fact, in some of the back channeling that I've been doing with cardiologists and vascular neurologists, again, mixed opinion about sort of whether or not this is a good idea for us and whether or not we should be going down this road. But for sure, one of the people I spoke with raised the point that some engineers that they were talking to don't even actually believe it's possible, right? And so this idea that like whether or not we're going to engage with the sort of ethical issue of deploying facial recognition technology, it's not entirely clear that it's actually possible. From what I understand, there are more studies in the pipeline right now that look at facial recognition technology as a way to maybe try and continuously measure blood pressure. And so that is something that I would also reject. But, again, it's this idea that the studies are happening. And I think one of the things we might need, in addition to sort of individual researchers kind of objecting or particular communities objecting, is a more sort of organized institutional kind of rejection of these kinds of technologies, because I think there needs to be a recognition that there is the sort of racial justice issue, right? There's a sort of carcerality issue, but also, there's this kind of issue about whether or not it's possible. And so on one ground or another, I'm fine, whichever one it is. I would like to see this kind of rejection, but I think you do raise a good point that it's not actually clear whether or not this is a truly effective technology.
Yeah, I appreciate your comments. Thank you.
Thank you. Yeah.
Riz, I'm seeing you in the chat too.
It's not just that's the thing. I'm sorry, I'm just going to react to that. It's not just the media overhyping it. It's providers and researchers as well. And so there is a bit of a feedback loop, right? The comment was it might be the media overhyping the study, which yes, absolutely. There was sort of a lot of fawning praise, but also it seems that there are providers who are, I think, uncritically sort of accepting the idea that this is the future or this could be the future. So, again, I think someone needs to be the fly in the ointment.
If no one's jumping in, I could ask the second half of my question.
Please do, Ben.
So when we're talking about such systemic oppression, I'm curious how you personally navigate strategically where you intervene, and both in terms of the conceptual lens you bring to understand these interrelated factors, which I really appreciate how you foregrounded the importance of contextualizing these kinds of medical interventions within the scheme of the carceral state, for instance, and all the different kind of ecological connections that we might be able to trace. How do you approach it? Because tell me if I'm misunderstanding here, but I understand your work to have an activist approach. And so as a scholar activist, how do you parse where to focus and where to intervene in such a systemic issue?
Yeah, I think one of the things we have to recognize is that the voices of community members have to be sort of paramount here. And so it's important to make sure that we as scholars are sort of recording that and sort of interacting with community members who are aggrieved or who are sort of subject to these technologies. And so that is vital. I've done a bit of that with my work on sort of health insurance activism and kind of understanding how people talk about the effects of health insurance precarity, for example. And so I think it's vital that we sort of engage with the voices of communities. In this particular, at least strand of this work, I'm focusing a little bit more on providers and institutions because I think there needs to be a bit of a kind of roadblock in the kind of development of these studies, because we can talk about the effects of communities after the fact, or we can talk about sort of anticipatory claims about sort of the harms of these technologies from the perspective of communities. But perhaps it remains to be seen whether or not that is persuasive to all stakeholders, right? And so I think another strategy, maybe not the core strategy, but another strategy is to target these institutions and these providers directly. And so to the extent that I have some level of access to healthcare providers now and people who work within these organizations, what I'm trying to do is kind of back channel a little bit to get a sense of what the temperature is and to get a sense of how they understand the kind of function of innovation, right? And so to think about sort of how they're thinking about these things, and then to use that to try and sort of gauge my responses and to gauge my interventions to make sure that they are sort of legible to them. Because I think we can talk about, you know, harms to patients or harms to particular patient communities, but if that is not necessarily effective to all stakeholders, which again, I'm not making a claim that it is or it isn't, but to the extent that it might not be, then we may need other ways. And so I think the idea basically is to not find one approach, but to find as many approaches as possible to make sure that whatever the core sort of critique or intervention is developed in consultation with people for whom these technologies are harmful, and then also deliver it to populations and to stakeholders who maybe have the power to do something about it. Because we can talk about sort of what patient communities can do to protest and to just not use these technologies. Like, I think refusal is a great tool. You know, I refused to use these technologies even as I was a part of a research center, but that didn't change anything. Like, that wasn't derailing the process, and that also wasn't my intent, you know what I mean? Because I think there is still a benefit to trying to figure out a way to use innovation to distribute its benefits more equitably. Like, that is still something we can pursue, but to the extent that we can have the ear of people in particular positions of power, then I think the idea is, okay, what is legible to you? How can I best make this critique to you? And then make that sort of in as many paces as possible and as forcefully as possible. And I think it really just has to be as many of those as approaches as possible.
Thanks.
Sean, I see something from you in the chat.
Yeah, I think we're seeing generally a lot of regulation emerge that is wonderful to see. It's exciting to see. I just want to put this article out there because it's not stemming a lot of the alternative forms of investment, particularly venture capital investment, which is skyrocketing in facial recognition technology. So the usual sort of complacent kind of message.
I appreciate it. Thank you.
I guess that, Sean, the part of your point and the previous question also makes me wonder, Beza, would it make sense for this kind of research, and it may not be, you know, it may not make sense for you to do it, but would it make sense for this kind of research to try to develop sort of health economic scenarios for the various alternatives that that you sketch out, because, you know, the system is supposedly geared toward delivering lower cost stuff. The fantasy of introducing new technologies like facial recognition, like digital health anyway, is that cost goes down because, you know, people are being replaced. Basically, and that might help, you know, at least clarify some of the relative claims between how accurate the technology really would have to be compared to a set of lower tech or community-based interventions, where we have a lot of data about how that lower tech actually functions. And, you know, whatever one thinks about, you know, assigning, quantitative values to, years of lost life or whatever it happens to be. That's a plausible tool for doing some of the anticipatory work that you're pointing to.
Yeah, I think that would make a lot of sense. I think that could in particular be persuasive to people who are sort of within these spaces, but on the clinical side and not necessarily sort of thinking from the perspective of a patient, right? And so thinking about efficacy in terms of economic impact, for example, could be useful. I think one of the issues here is that it feels like we're in a bit of a gold rush where everyone's just sort of without perhaps a lot of really critical reflection, sort of rushing to figure out the best way to design these technologies with good intent, right? With sort of making sure that we're serving patients, but it's very much like, well, we're comparing these studies, we're doing meta-analyses, we're trying to develop this technology, whatever it happens to be, but there doesn't seem to be this sort of effort to kind of stop and really reflect on sort of what these technologies mean sort of in society, right? And so I think any kind of opportunity to reflect in this particular forum, and in particular, opportunities that will be legible to, I think, these audiences, so this kind of economic analysis, I think, could be really useful to sort of make the argument that, yes, we may be designing new and exciting technologies, and yes, we may be partnering with industry, and we may be, making use of the iPhone or whatever wearable or whatever, right? Like that's all good and well, but is this having the effect that we want it to? And I think that is one of the sort of linchpins that's kind of missing in at least the kind of developer side of these technologies. And so even though I think some of these developers and makers are working with community members, right? I'm not certain how comfortable maybe community members are in sort of offering very clear and maybe direct critique, and then also whether or not these centers are kind of open to that kind of critique, given that, for example, they're being funded by even larger institutions and larger sort of moneyed organizations, right? And so it may well be that, our charge is to do X, Y, and Z, and whether or not, it's really making this kind of a difference, that's what we're being paid to do. And, there are jobs on the line and publications on the line and, corporate relationships on the line. And so I think there is an opportunity to kind of have that kind of discussion about sort of what kind of evidence is most persuasive and useful, and for whom that kind of evidence needs to be applied, I think.
Great, thanks. Any last questions for Beza? Hearing none. Thank you so much. This was a lot of fun.
Thanks.
Very interesting. And we will see you next semester for more enlightening lunches.
See you later.
Maybe even with lunch.